Welcome to Swallow the Gap, the podcast that delves into the critical world of dysphagia practice and education. I'm your host, Dr. Tim Stockdale, and I'm thrilled that you've come to join us for the second season of conversations aiming to bridge gaps surrounding dysphagia intervention. Swallow the Gap podcast is a production of Gap Education, and we are predicated on a mission to improve dysphagia care. Nothing we say is legal advice. Nothing should be taken without scrutiny. While we strive for accuracy, we do not imply perfection. We value diversity in backgrounds and opinions, therefore our guests will not always reflect what we believe. In fact, we may change our minds as we learn more because this is how progress is made. Through critical reasoning with open minds, we serve as catalysts for advancement in medically focused speech-language pathologies. This episode is brought to you by Phagenesis. For stroke survivors with severe neurogenic dysphagia, the Phagenix neurostimulation system provides implant-free treatment through pharyngeal electrical stimulation. Learn more at phagenesis.com. Welcome, everybody. Joining me today, I have Doctors Debra Suiter, Giselle Carnaby, and Martin Brodsky. How are y'all doing today?
Good.
Doing well.
Doing well? All right. So the reason why we have so many people here today is there was an undertaking earlier this year that extended well on before that about the idea of defining dysphagia. So thinking about that for a second. Defining dysphagia. Most of you who are listening to this evaluate and treat dysphagia every day, so you probably are thinking, well, that's stupid. Everybody knows what dysphagia is. If you were to think that, I am going to throw you to the wolves here and let them dissect it for a second. What is the problem with thinking that we understand the nuances of what dysphagia is?
Well, I can go first. I think we know from our review of literature. So what we did an undertaking that started with a discussion that Marty and I had years ago about how we're defining this thing we all think we know. Because again, yes, you tell people you're having a conference on defining dysphagia, and it sounds like a no-brainer. Everybody knows what we're talking about. But talking to Marty and talking to clinicians and then diving into the literature, and Giselle was really instrumental in helping us figure out how we started to look at this. We realized that we're all over the place, at least within the research literature. There is no agreement amongst researchers, amongst clinicians, amongst professionals from different backgrounds as to what this thing is that we're all talking about. Again, we all think we know, but it became very clear we don't.
What sort of variability did you see? Like what kind of represents maybe some of the extremes?
Do you want me to go? So,
in the literature, the extremes could be as simple as just a statement of swallowing difficulty to a specific scale that very few people use. There was one that I actually had to look up because I'd never heard of, and that even in a single publication, one group of people might define dysphagia 6 different ways. So which one is it? So we don't even agree with ourselves within our own publications, which was kind of startling.
What do you think some of the implications of this are within the research for those who don't have PhDs like the three of you?
I don't think that helps us, by the way.
I think at the very least, a common language with a common understanding within healthcare. And by healthcare, I'm going to be as broad as the person who answers the phone and says, and hears from the patient that they have dysphagia, all the way up to and past the healthcare provider who gives that care in any form, all the way to the third-party payer and government officials related to Medicare in defining what's going to be reimbursed based on what, in what coding, et cetera, et cetera. It is a ubiquitous problem across the entire domain that is swallowing disorders.
I'm thinking of something yesterday. I had an internal chart audit at one of the outpatient clinics I work at, and they have a special place for everything. And I had my dysphagia diagnosis there, my R code, but it wasn't in the right place. And so because it wasn't in the right place, it didn't get populated onto the certification letter that the physician signed. And it was sent back, and it was something that I needed to resolve. And so just thinking of that, if you don't have a diagnosis, insurance is not going to pay for treatment. You're not going to pay for treatment. And so I think just understanding what that is so that the physician can say, well, yeah, they do when they sign the authorization, or an insurance companies don't have something to contest it with, it makes a lot of sense. So just, the sheer importance from a payer source. I mean, that's not the biggest thing, but that is a pretty big thing.
I mean, even when you're talking R codes, it's a symptom code, not a diagnostic code.
Okay.
So the implication for funding and for reimbursement is different for what we do. And then what constitutes that R code? And it's different in different clinics. So some symptoms we recognize as associated with swallowing disorders where others don't. And so that's part of the problem with definition.
Yeah.
And so just even using that code becomes variable. And that puts us at risk of not being paid for our services.
So
in talking about fund, when you speak with NIH program officials, you'll note that dysphagia does not have a home. That is, that swallowing and swallowing disorders is not expressly stated in any mission statement across all of the institutes at NIH, to the point where program officials say, that's not us, that's them. And now it's a little bit of pass the buck as to what it is that's going to be the focus of the grant. So, for example, many clinicians in speech-language pathology, many researchers in speech-language pathology think that speech-language pathology and audiology have a home, if you will, within the National Institute for Deafness and Other Communication Disorders, or NIDCD. That is, in fact, not the case. It's not that the profession has a home. It's that the topic has a home. Okay? So I want to draw the distinction specifically within swallowing disorders. A researcher who puts in a grant that deals with stroke, up in the air immediately is going to be NINDS in neurological disorders. It could be NIDCD, or if they're old enough, it could be the National Institute for Aging, NIA. That's the issue that we face when it doesn't have a home. Okay, and let me be very clear. Many disorders, many diseases don't have a specific home within NIH. It depends on how you write the grant. But not having this well understood certainly contributes to the problem in not knowing where it exists.
So just real fast, back to somebody who's listening and might not even know, what is an R code? What is a G code? Thinking of the idea that when you're inputting a diagnosis, you're trying to get treatment for somebody who you believe has dysphagia that's impacting their life in one way or another, there's an ICD-10 code that you have to put in to tie to that. And so stepping back even further, Giselle mentioned an R code. So what's the difference then between an R code and maybe a more pure diagnosis code?
So R is symptom only. Okay, which means it extends from another diagnosis code. So there has to be a full diagnosis code. So for any one patient, the diagnosis code could be specific for stroke, or it could be specific for head and neck cancer, or it could be specific for ALS, And so then, depending on the symptom, there's an associated R code.
Okay.
So, for example, say the diagnosis is unknown and they can't work out what it is. Like, let's say it's a
functional dysphagia,
collagen vascular disease, and we haven't typed it appropriately. So that patient doesn't have a clarified diagnostic code, but they may have a whole host of R codes, right? And so that makes it really difficult in terms of if you're trying to bill at that level, your billing codes follow your coding system, and billing for an R code is less than you'll get for a diagnostic code.
Okay. Very interesting. All right, Marty, sorry, I didn't mean to interrupt you.
So, this thing about defining this term has specific implications, not just for us all being on the same page, which is also really important, but also on how we get paid and how we identify our services and how we demonstrate that our services are of significant impact.
Okay.
So clinically, yeah, it makes a big difference.
So we have a better idea of what we need to do. What have been some of the barriers in being able to get toward this goal, this undertaking?
Well, I think that the biggest barrier that we've identified is just realizing the discrepancies and the fact that so many of us are looking at this thing called dysphagia in so many different ways. And a lot of us are very wedded to those beliefs. So trying to take a step back and to understand that we need to reach some common ground, I think has been an issue. Certainly, I think the other thing that we realized when we took this on is, again, we thought this was a very simplistic sort of task, come up with a definition for dysphagia. And of course, we thought, we could accomplish that in a fairly quick manner. And what I realized, one of the biggest takeaways from this conference that we had a couple of months ago is we spent 3 hours discussing a framework, which was necessary. We needed to take a step back and come up with a common ground, but we couldn't even agree on that. So this is I think it's going to be a much longer process than any of us realized at the start of this.
I agree. I think I want to align it with a song call and say it's a climb. We are at the beginning of this, and that's what we've come to realize. And all the hard work has yet to happen. And so I think one of the things we can take away from the conference we had is that this is a call to action, not just for us, but in the future to get people moving beyond where we are now. We have this mandate that everyone agreed, this is a good thing. We should be pursuing this. But then beyond that, how are we going to do that? So that framework is really important. And then beyond that, divide and conquer into smaller, more digestible chunks as we move forward to develop it. It's going to take more people, lots more people.
In the end, and whether that end is 5-10 years from now, or it's 30 years from now, well beyond my retirement anyway, I think we're going to have a pretty solid product in terms of many disciplines in agreement on how we move forward, that in the end will strengthen every single aspect of funding, of diagnosis, of treatment, of the way that we think of, the way that we approach, maybe just even a solidified approach to research, and that we're all finally on the same page, and we can all think about it very similarly.
And I think also, Tim, a lot of the time when I'm out and about talking to clinicians and people who are just, they're slogging away out there, I hear, we're not well respected. What we're doing isn't well respected. It's not well appreciated. I don't feel like they take what I say seriously enough. Well, part of that comes from the fact that we're delegated to symptom-based approach rather than, hey, we're going to affect a change in something that patient's experiencing that is life-altering. And that's where moving this from R to something more like G is really important for the professions that work in this domain.
Dr. Greg Jica, who is the neurologist who joined us for the past 2 years, made a point, and this one kind of sticks with me quite a bit right now. Just for background of those who were not present in the conference and not aware of his work has primarily focused around dementia and issues associated with mild cognitive impairment. And he has been on task forces within the groups of neurology and others who have addressed what exactly is mild cognitive impairment. And he was one of the foremost leaders in spearheading how to get there first, and secondly, moving from the R to the G code. And one of the things that he brought to light was that in order to do that, you need buy-in from physicians and broadly the American Medical Association in order to do that. SLPs simply are not going to be successful by themselves. That's straight up. No mincing words here. We need partners in this. And our partners, every single one of the rest of us, outside of nursing, outside of respiratory therapy, outside of physical and occupational therapy, they're all physicians.
Mm-hmm.
We need to partner with them. We need to work with them. We need to be on the same page with them. We need to move in parallel with them. Certainly, we can have disagreements, and disagreements are going to make us better. But in the end, and at the end, there's going to be a collaboration that takes place where all groups are on the same page. And you're going to have people who can take this to the AMA and say, it's time. We need to move from the R to the G.
I kind of have a one-track mind in this, that I'm looking back at this systemic issue. Like you mentioned, the idea that speech pathologists are not going to do this on their own. We need partners to be able to appeal to the AMA to make something happen. But also, I step back and think about just our training. Again, I also see like the Dunning-Kruger in everything. You know a little bit and you think you know a lot. And how I believe we're trained as speech pathologists, we learn so little about so much. And so we have very little depth. And so when it comes to something like dysphagia, which, as we all know, has tremendous implications on the individual's health, well-being, quality of life, so many different areas, there is so much depth to it because it involves interplay between various body systems. If you get an individual who's 80 years old and they're healthy, but their functional reserves aren't what they were when they were 20 years old, and they get sick, and how that can cause a transient, so to speak, manifestation of dysphagia, but just the complexities of this. And so I think one of the things that we have going against us right now is our training. Just our training and being able to give us the foundation to better understand this and to better understand the impact of it on health, because we're talking about moving it from a symptom to something greater than that, to a condition, it sounds like. But if we don't understand how all of these things interact, how are we going to be able to advocate for that? So I see the benefit from a credibility standpoint, if we partner with laryngologists and gastroenterologists and neurologists and so on going into this, but also from the perspective too of getting their understanding of how these things tie together. So that need for a cohesive web where we can all communicate together. What is interesting to me at this conference, for example, the majority of individuals were speech pathologists. How do we get that buy-in from physicians? How do we get more physicians coming to the table and being willing to discuss this so we can move forward with more momentum?
Well, I think that the thing that really stood out to me is you're looking at the three of us that organized this conference. We're speech language pathologists. And certainly while we reached out to our physician colleagues, having somebody who's going to champion our cause on the physician side of things is we just need to find somebody who's invested enough to do that. And it's sad to say we should be able to advocate for ourselves, of course, but you're right. We need that physician buy-in and so we've included them. We deliberately included them in our conferences, But again, we didn't have nearly the representation from the physicians that we did from speech.
And some of that, to be honest with you, is a meeting logistic issue as well, because, getting physicians' time means providing CME credit and to have physicians advertise for us. And that, Rome isn't built in a day. We did get physician representation at that conference. In fact, Dr. Jika spearheaded it. So, we do have some depth on the bench, one might say, but that depth certainly needs expanding, and that's food for the future. Absolutely.
I think there's a little bit of a culture among the societies related to dysphagia, in that I think every single one of them, the majority of the attendees to any one of those conferences, the majority of the members to those to those societies are speech language pathologists. So there is a culture that's part of this. That's not to say that, across the societies, to give you some idea, dental is a gigantic part of the Japanese Society for Dysphagia Rehabilitation. It is not a giant part, except to say that we have dentists from Japan who are members of the Dysphagia Research Society. Okay. There is a culture here, and it's within country, never mind across countries and around the world. So we made very big attempts to getting people who wouldn't even ordinarily attend Dysphagia Research Society in North America. We reached to gastroenterology, neurology, physical medicine and rehab, intensive care, pulmonary and critical care medicine, ENT. Every one of those were not only on the invite list, but they were present. So yeah, as Deb and Giselle have said before, the depth is certainly there. I think what we need to work on right now is that there's a lot of interest by virtue of those folks to be there. I think we need to work on the numbers. And I think that's part of the problem. It's not just what we're doing. It is more broadly the way that the culture has evolved related to swallowing and swallowing disorders. And let's bear in mind, and I'm not going to throw anybody under the bus here. In fact, I'll defend it. Dysphagia, as has been brought to light in speech language pathology, only began in 1992 when it was recognized. So here we are 32 years later. Okay, we are young. There's a lot more to grow.
Some of us were there when it evolved.
Yeah.
I was on my third grade playground. Oh, man, a lot there. It's something that I think is very promising. So Dr. Jaika, he is a colleague of Dr. Suiter, right? Okay. So, and he was, not just coincidentally instrumental in the advancement of defining dementia or mild cognitive impairment. Forgive me, I'm going to miss some of the nuances of that. But so you and what you've been doing, Deb, have had enough credibility and enough influence with him to be able to get him on board with this, which I think is great. And it speaks to the potential that is there for when speech pathologists get a lot of depth in dysphagia and really, really understand the nuances of what we're talking about, that we can get buy-in from others outside. And so I guess that's one thing I'm taking away from that. But also I'm thinking, oropharyngeal dysphagia as a physiological concept, I mean, that exists in our wheelhouse. Like, that's our thing. If you're talking about esophageal dysphagia, it's primarily gastroenterology. And if you're talking about, the anatomy and physiology of the upper aerodigestive tract, at least the pharynx and the larynx, then you're, otolaryngologist. But when you get into the physiology of it, that seems to be something that primarily resides with us. And we're at a disadvantage because we're not physicians. And I'm not saying that shouldn't be there. I think we can do it, and I think we can do a great job. I think there's some things that we can certainly tweak in education and become better. But considering it's just been since 1992, I mean, that's fairly impressive. I think that's fairly impressive that we've been able to get as far as we have gotten. And so I don't think the effort's unnoticed.
I think, Tim, you also need to realize that other countries are doing things differently. So at the moment, you can take a specialty degree out of Belgium and you can become a deglotologist. You can become a specialist in this area. I think with a little crystal ball going forward, you're going to see more of that.
Yeah, it could be great.
And that, by the way, is not an SLP degree. Physicians are taking that degree too.
Now, if that does catch on, how do you see that influencing this all in the future? And I guess, that's so potentially so far, maybe it's hard to speak to.
Well, if we're able to, as a group, a multidisciplinary group, get to a definition, I think that just ensures that pathway even more.
Absolutely. So we've talked about a bit about what we need, why we need it. We talked some about how do you think we're going to get there and the challenges that we're going to have. Let me just, if you were to, we've talked about different nuances to that, but if you were to summarize in your mind how you think we're going to get there and maybe one of the primary challenges, could I just hear a little bit like a brief synopsis from each of you? And if you wouldn't mind, I should have asked you to do this at the beginning. When you say this, just say who you are the first time so people know your voice.
Sure. So I can go first. It's Deb Suiter. So in terms of how I think we're going to get there, I think we've hit on a lot of it already. I think we need to get buy-in from the groups that are the key stakeholders here. And one of the things we haven't mentioned in this discussion is we need to get buy-in from patients and from patient advocacy groups as well, and third-party payers. So I think getting the right players to the table. And again, we're very proud of the fact that we did have as many different disciplines represented at this conference and the conference we held previously. But getting that buy-in and then realizing that we have a huge task ahead of us, and breaking it down into smaller parts and coming up with focus groups that are going to be able to take on that task. It's a task that's bigger than the three of us, and we need to start recruiting more people to get involved.
Okay, thank you. Who wants to go next?
Me? Okay. So this is Giselle Carnaby speaking. So I see this as a multi-year action. And so I think what we're looking at is the development of working groups on specific aspects of this so that we can start to break down that categorization that we began to investigate in this first conference. I think we're going to have to work on partnerships, and their partnerships with other societies, not just Dysphagia Society, but also with the medical societies at different places that have an invested interest at the moment in this symptom code and what it would mean for them if this changes and it advances. And I think along with that, you're going to need to start to see a regular yearly review of progress of those groups coming back to a central body. And that's how medicine has done guidelines and building from R to G codes. And I think we're going to have to follow the same tried and true pathway.
Well, I'm Martin Brodsky, and I agree with both of their perspectives. And I'll add perhaps one more. And that is just to say that it's going to take all of us working together. It's not one group, it's not one profession, it's not even one country, but it's all of us working together toward this common path. So, I'm aware that at the European Society for Swallowing Disorders conference, there has now a combined or coalition of what is now the World Dysphagia Coalition across 5 groups around the world who are these societies that exist. So we've moved in the direction of unification, in that now there is one coalition across these 5 major groups of membership, country-based or at least continent-based societies related to dysphagia. That's a step in the right direction. And now we have a way, at least in this consolidated format, to bring all of us to the table a little bit easier than we did even moments ago. That's what this is going to be. It's going to be consolidation. It's going to be ultimately consensus. And make no mistake, even though we're talking about professions and countries and so forth, it's still going to be governing bodies like the American Medical Association that are also going to have to be a partner in this. It's just a little bit later down the road, once we have something a little bit more solid that's evidence-based, that we can present them as a unified format.
I mean, you look at such an evolution in thought in this when you think of just how do we define dysphagia versus the more you're digging into it and you're looking at all the nuance, and you're looking at all the things that have to happen for us to get there to a unified definition, I think it's extremely difficult to see, if not impossible, to see the magnitude of how many, it's not small steps, but just how many steps it takes to get to this. And so it looks like it's unfolding really beautifully to me. There's been a precedent set by others within this. So there's a pattern. There are people who are invested in this. It sounds very promising. And I really personally appreciate that in a number of levels. I want to, so you, Marty, and this is for anybody, but you had mentioned it's going to take all of us working together. Mm-hmm. I'd like to really wrap up with, so for listeners, for those who are here listening to this in whatever setting they might be in, what does all of us working together look like? What might it look like for them? What might their actionable steps within this be?
It's interesting you mentioned that, because as you were talking just now, I was thinking about, what are the steps? We haven't even defined those yet. I don't think anybody has. This is, in every aspect, a dynamic situation that is responsive to the information that's gathered at every single point. So to know where we're going to be tomorrow, sure. We're finishing up our scoping review. We need to, put together a summary paper for what occurred at the conference. And both of those papers in and of themselves are going to suggest steps to move forward. Whatever happens in those next steps will dictate where we go next. I don't have those answers. I don't think anybody does.
From a broader perspective, and I know I beat this dead horse all the time, but just the idea of us continuing to build credibility, to not just credibility. Let me take that back. Us building the depth of our knowledge. Building the depth of our knowledge within dysphagia, within the populations that we work with, understanding the etiologies that lead to what is this, symptomatic diagnosis of dysphagia right now, better understanding that, I think is going to help us to better understand the reason for this, why we need it. It's going to help us to build credibility, but also, what about the idea of what you're doing? You're raising awareness of it. How many people just in the last 3 months through a conference that you all have held, this has been placed on their radar. And now they're like, I didn't even know that was a problem. But now they know it's a problem, and they have some sort of thing that's driving them with purpose to get this accomplished. And so just, I don't know, a couple of thoughts. I like to oversimplify things like that, but I know it's a lot more complicated.
I want to come back to your credibility comment. And I don't want to underestimate at all the amount of credibility we already have. Since, let's just call that 1992 benchmark, okay? 32 years of research, 32 years of experience, multiplied by the number of clinicians and researchers that are part of that. There's credibility there. What we're trying to do, I think, is refine and get better reimbursement and get better acceptance across the healthcare professions for what this disorder is. I think part of what you just mentioned in terms of more people now being aware, that was a huge first step in all of this. That was this year. It was awareness. It was bringing everybody on. It was getting everybody onto the same page in some form of consensus. That's a giant step. Think about the hierarchies that we've all learned as clinicians with regard to cognition. Awareness and sensation come first. If you don't have that, nothing else matters. That's where we are. And it just builds from here.
Love it.
Yeah, I just want to echo a little bit of that, but also put something in people's minds. I see what we're doing here as much like when the World Health Authority created the ICF. All right. It's just as complicated. And they did it over a series of years and developing this conceptual framework and then slowly building the framework out to the different definitions of different components that contributed to that. This is kind of where we're going. We can take lessons from other people, but all of those people that contributed to that framework from a multitude of different professions, that's us.
Very good. Well, thank you, everybody. Again, we have Doctors Carnaby, Brodsky, Suiter, and myself. Thanks for listening. If you have any questions after the fact, don't hesitate to reach out to me. I can kind of forward the emails or contact as needed. And I guess that's it. That's it for today. But this is just one little tiny baby step in the mammoth elephant we're trying to eat here. How's that for an outro? I don't know, man. I got stuck. But anyway, thank you all for being here. It was great. Appreciate seeing you. And hopefully we'll talk soon.
Thank you.
Thank you.
As a reminder, our episode sponsor is Phagenesis, maker of Phagenix neurostimulation system for pharyngeal electrical stimulation, not to be confused with neuromuscular electrical stimulation. Please visit our sponsor at phagenesis.com to find out more. Thanks for tuning in to another episode of Swallow the Gap. Love to hear from you, so please reach out anytime. When you have a moment, share this episode with a friend or tell a colleague about us. I hope this episode has been beneficial to your practice and has sparked your curiosity.